Good morning, everybody. Dr. Perlman coming to you live from the house. And it's day one after the surgery. We had the partial laminectomy and foraminectomy. Some may call it laminotomy or foraminectomy of some sorts, but they are basically dremeling around the inside of my spinal canal at the bottom to make room for the nerves and the thecal sac and the caudal equina and the conus medullaris and all those parts of the, not really spinal cord, but spinal, the continued spinal nerve, dura, meninges, and everything else that goes down there to innervate everything that goes below the waist. And the reason why somebody like me might be walking around like they've got a crooked back. Here's what's interesting. After the surgery, the doctor went to my wife and said, hey, you know what was interesting is we found a incidental finding, which I knew I had. It was called spina bifida occulta, but down there on L5, but I didn't really think much of it because they call these incidental findings. Now we could go out on a limb here and say that is nothing congenital, that is an abnormality or a degenerative or arthritic change over time happens with no reason. It shouldn't be incidental. There's always a rhyme or reason. The body is smart, not stupid. However, I never thought much of this because I was born with it, but I didn't start having back pain until a football injury in 1998, 1999. And then the pain really didn't get debilitating until about 2006 or so. The thing is, after all this time and then finally getting the surgery, which I am glad I got no matter the outcome because it's already better, but we'll get into that. The number one common symptom associated with spina bifida occulta is actually spinal cord tethering or spinal dura or meningeal or we'll just call it spinal tethering, which is interesting because that's a descriptive term I would use a lot for lumbosacral plexus nerve-like injuries, sciatica-related injuries, fascial distortion type injuries. I would always refer to as tethering, and that my cord always felt, or my fascia or my nerves always felt like they were tethering, pulling. It means pulling and stretching. It was very interesting. And because I never really had much success with spinal decompression via the y-axis, I shouldn't call it negative y-axis, going down towards the feet is interesting, as I believe that was irritating the nerve roots more than something like y-axis traction, positive y-axis traction on the head, almost like a Y-strap maneuver or a ring dinger, please forgive the expression, even if we didn't do like a fast pull, just the slow pull on decompression, having that be able to be a little bit more relieving on a temporary basis anyways. So very interesting finding or associated symptom along with what I was dealing with. And one of the last things I just want to say is, already the pressure in my low back is significantly reduced to almost nothing. I obviously have a lot of incisional pain where the bones were being sawed a little bit, if you will, and where the stitches are. That's totally to be expected. I see myself making a very fast recovery. I will say that the associated recovery that I'm experiencing, hopefully I'm not rambling too much, is what I call fear avoidance behavior or fear learned behavior. So even though my back isn't per se in any kind of debilitating pain getting up or moving around, it's the thought of that the pressure that I feel in the incisional site could get worse. I sort of carry my shoulders high and maybe I'm a little bit crooked as I'm recovering from this. But I, again, anticipate having a full recovery. I have no radicular symptoms whatsoever. I have no lower back pain or pressure whatsoever in terms of where the pressure is through the lower part of my spine. Even weight bearing or standing as I wake up, that is completely different. And as the last sort of message out there to people who hear this video, this is years and years and years and years after I probably should have considered getting it. When I say getting it, I'm talking about a very moderate invasive level of surgery for my spine. Would I recommend to someone that right now they go and get a full-blown fusion because they want to completely eliminate any potential type of mechanism of injury with instability? No, not at all. That's way too invasive. They should always go least invasive first. It's why people should start with the chiropractor. It's why people should utilize chiropractic for as long as they can. Again, I make no, how should I say, I don't want there to be any confusion. the first thing I'm going to do when I start to heal up and feel better is I'm going to go to my chiropractor. I'm going to get adjusted. Obviously not on the site of surgery because it'll still be too tender to move, and we don't want to trigger any, fast rebound effect on like a muscle spindle that would cause a spasm or uncertainty, again, that fair learned behavior over time. What we want to do is be able to get probably that thoracolumbar junction moving. We want to stimulate the lower dorsal neurons and receptors that start at like a level of the thoracic spine and go downward, and be able to adjust that in an anterior manner. Like a lot of you of my patients know that I do this anterior maneuver for people who have a lot of the lumbar intolerance, and we then are able to achieve lumbar tolerance. So therefore, you other chiropractors out there who hear this video, that's a very real thing, as opposed to developing prone extension intolerance over time. But again, like that's just something that we'll talk about later on if we ever do any kind of, not seminar, I don't do seminars, just kind of like tutorials, or you come in and want to learn from me. But everything's going good. I'm very happy. Again, I'm very happy that I got the surgery. Do I think everyone should run to a surgeon? No. Again, it took me over 20 years with a lot of the same symptoms before I finally decided enough was enough, and I had to get this stenosis. And there was objective level of stenosis. There was clear, what we would call lateral recess and foraminal stenosis bilaterally. That means both sides. L5-S1 nerve roots being compressed, L4, L5 nerve roots being compressed, and the lateral recess and some amount of central stenosis between L4, L5, L5-S1. So you can see there was clear issues that was causing me a lot of pain and discomfort. And it was just, my plan is to be practicing chiropractic until I'm very old, like very old. I love what I do. I love giving chiropractic. I love receiving chiropractic. I think chiropractic done right and done specific is still one of the most important things, if not the most important thing you could possibly have in your life. And I think knowing a good surgeon who has great outcomes and is competent and communicates with you and doesn't treat you like a number. And like I have an amazing spinal surgeon. I'm very fortunate. His name is Sean Jones Quidow. He's out of Dallas, and I believe Frisco is another office. I cannot say how happy I am to have him as my surgeon and my friend and my colleague. And I don't know if you call an MD and a DC a colleague, but I do. And we work together, and I've sent him other people in the past that have had phenomenal outcomes. That's why I knew I was making the right decision going with him. And that is the end of my video today. I will keep you updated tomorrow and the days forward as I continue to have more and more clear thoughts on what we need to talk about. Thank you.